Hello, good afternoon. I'm Carolyn Robinson from Nutrition Services, and I'd like to introduce our speaker for today, Dr. Ty Kirkpatrick. Dr. Kirkpatrick is presenting on appropriateness of parenteral nutrition versus enteral nutrition, and our program's underwritten by an ed grant through OSUMC, Grad Med Ed, and a disclosure statement's been signed and is on file in the Grad Med Ed office. That being said, Dr. Kirkpatrick is a fourth-year surgery resident here at OSUMC. He's served as chief intern, student ambassador, and in 2011, he won the Outstanding Medical Student Surgery Award. Today's presentation begins with a study that he completed here in 2013. He looked at the appropriateness of parenteral nutrition usage by comparing it with the most recent ASPEN guidelines. These guidelines and misconceptions regarding enteral nutrition will be reviewed today. And Dr. Kirkpatrick will also touch on those forms that we left on your tables. They're new TPN order sheets that will go into effect this coming Monday, March 16th. And Dr. John Burry from Pharmacy is also here to help answer questions about them. So please welcome Dr. Kirkpatrick.
Thank you very much, Carolyn. I appreciate that. Excited to be able to present here this afternoon on something that I think is important, personal interest of mine, and I know important to everyone else here in the room, talking about nutrition for our patients. So, getting on into the lecture here. You bet. Okay. That's not an actual patient, by the way, so there's no HIPAA violations here. We good? All right. Thank you. All right, so nutrition. We all know it's important. We certainly know it's important for our patients in a critical care setting. Typically, these patients are going to be under some sort of catabolic stress state, which is going to be coupled with some sort of inflammatory response syndrome, and then it's complicated with their increased infectious morbidity, prolonged hospitalization, higher mortality rates. And even though I think we can all sit here and say, yeah, nutrition is important, it's not always, I think, on the top of our priority list as far as managing these patients in the ICU with all their other acute illnesses and situations that are occurring. But the significance of nutritional support cannot be overstated, and I hope I prove that to you here today. I think we're going to review a lot of things you guys already know, and then hopefully just kind of give you some motivation to really push forward as far as providing our patients with appropriate nutritional modalities. Here's just some pictures of our options here. There's tube feeds, TPN, and then good PO intake here. So we're going to kind of look at the ASPEN guidelines. That's the American Society of Parenteral and Enteral Nutrition. That was the basis of the motivation of creating a research project that was done here last year that really kind of showed how well were we performing as far as using our TPN appropriately. And the motivation came really just in small group discussions of, when we were going around rounding on patients of if they seemed weak or needed nutrition. Well, let's give them some nutrition, so let's give them some TPN. And we thought that was a boost in nutrition, but what are the guidelines for this appropriate use, and how safe is TPN? So as far as our study that we did, we, of course, used the 2009 guidelines, created a flow chart that was followed diligently in reviewing a 6-month span of charts that started back at the end of 2012 and extended into 2013. And basically, I was the lead investigator on it, but I had extreme amount of help from the registered dietitians here at our office, and a major thank you to all of them involved here. Listed their names here as far as on the paper. They helped gather information and review charts with me. It was extremely valuable in performing the study, and then as well as I reviewed all the charts myself to finally deem them appropriate or inappropriate use. So what were the results? We got 113 charts out of it. 8 were thrown out to inadequate documentation, but we were inappropriately using TPN 53.3% of the time based on the strict guidelines set forth by Aspen, which is the national standard of when is appropriate to use TPN and other things as far as enteral nutrition as well. Now, that number might not be very good, but actually other hospitals have shown worse numbers than us, actually. So this is certainly not just a local issue with the use of TPN. Top reasons why they were deemed inappropriate. The most common was the patient had not been NPO for more than 7 days. And we're going to go into the indications for TPN here shortly, as well as having documented GI function. That was 75% of the time the reason why it was inappropriately used. 18% of the time, maybe they had gone past the 7 days, but they still had GI function present, and we weren't using the gut. We were using TPN instead. And then, sadly, still 10% of the time, we had access, we had GI function, and yet we still chose to give TPN. And in most of these cases, they weren't TPN and enteral nutrition at the same time. We simply were not feeding the gut during this period. Okay, so what does Aspen say when we can use parenteral nutrition? These are the guidelines that are set out there. Number 1, they must be NPO for 7 days or greater with enteral nutrition, at the enteral nutrition not being available. And of course, this is in patients who are considered previously healthy without any protein-calorie malnutrition. So that goes to the second point. What if they come in with protein-calorie malnutrition? And if they are malnourished and enteral nutrition is not feasible, then it is appropriate to start parenteral nutrition. Malnourishment, basically, you kind of have to go off more history and physical exam findings here, because things we usually use as markers for their nutritional status, such as pre-albumin, albumin, they're been proven not to be functional really in the critical care setting. They're acute phase reactants, so they can't be reliably used. So if they've had recent weight loss of 10 to 15% of the income the last couple of months, or if their actual body weight is actually less than 90% of their ideal body weight, then they can be considered as malnourished, and they can be started parenteral nutrition sooner rather than later. Now, these recommendations are by far the most challenged and most controversial ones that are out there that a lot of people try to fight through and still give people TPN despite maybe not fitting this criteria. But they've been proven by 2 large meta-analysis studies where they compared it to the standard therapy, meaning we didn't feed them for 7 days, we used the gut when we could. And in basically every pathway that they looked at, it significantly reduced infectious morbidity and reduced overall complications when we did the standard therapy versus giving them early parenteral nutrition. And the 7-day thing is pretty important too, because they actually found that there is a point where we have to give them some nutrition. The farther out you go from 7 days, there starts to be an inverse relationship with the complications. So at 7 days, if they still don't have any way of feeding the gut, then we need to start TPN because of the eventual complications of not giving them anything. And their study went out to about a 14-day period and showed the exact inverse relationship there. So other reasons we can give when we give parenteral nutrition, if they have an major upper GI surgery that's expected. What's major upper GI surgery? It's like a pancreatectomy, esophagectomy, gastrectomy, those types of cases. And if enteral nutrition is not feasible, then it's appropriate to use parenteral nutrition. And there's some bullet points below there. If the patient is actually malnourished, again, those findings we talked about earlier, and their surgery is expected, it's ideal to start them actually 5 to 7 days preoperatively on parenteral nutrition and continue into it. This population of patients have shown the most consistent benefit of use of parenteral nutrition over the standard therapy when they have evidence of this pre-existing protein-calorie malnutrition. But it's just the surgery patients that benefit. The critical care patients never benefited from any early parenteral nutrition. And it's imperative to know that all the benefit that they showed was only when we gave it preoperatively as well and continued postoperatively. If we simply just gave it early postoperatively, all benefit was lost and we just increased risk. And again, the other kind of side point that they make is that, and it's made up here, is really if we need to expect to use parenteral nutrition for more than 7 days, anything less than 7 days, if you're thinking just a short-term boost of nutrition, that there's no improved outcome by using a short dose of parenteral nutrition, only increased risk to our patients. So talking about parenteral nutrition, why is it so important to have standard, these guidelines for parenteral nutrition? Is because there is so many risks that can be associated with it. It's not just a benign therapy. Just like any other prescription we give, there's indications and side effects, just like an antibiotic. And so it's all ultimately up to the individual clinician to decide, are the potential side effects worth the therapy I'm giving them? And I think this was outlined in the book of current surgery, current book, that I think did a pretty good job of depicting the complications here as being technical, infectious, or metabolic. The technical reasons are obvious. We have to have some sort of central line access in all these patients, whether it be a PICC line or central line. And those inherent complications can be, of course, a pneumothorax, arterial puncture, brachial plexus injury, and even PICC lines. We just recently saw someone with a median nerve injury damage when they inserted the PICC line. So there's always potential there for issues. The infections reasons we know about. Some studies have shown up to 15% of the time patients with central lines have some sort of infection or potential sepsis associated with central line placement. But the metabolic reasons are usually more profound and more consistently complications that are going to occur. One that isn't actually super common but can occur in people who are previously starved or whatever is refeeding syndrome. Basically, TPN, when we start infusing TPN in these patients who are been malnourished and starved for a while, we shift from a more fat to glucose as the predominant fuel, and you build up a lot of phosphorylated intermediates that bind up phosphate, so you end up having low phosphate, so hypophosphatemia, hypokalemia, hypomag, all these things. And when you have those electrolyte derangements, you actually get less ATP. ATP is then also, of course, required for appropriate respiratory function and stroke volume, so they actually have shown an insidious onset of respiratory failure when these patients have these electrolyte abnormalities. Hepatic dysfunction is another common complication that usually occurs more long-term on parenteral nutrition. We'll talk more about it here in a little bit. Acalculous cholecystitis, the gallbladder is not contracting anymore. You build up in sludge and stuff, so you can get acalculous cholecystitis. Every electrolyte derangement is potential with TPN. And, of course, hyperglycemia is an issue as well as a potential complication. So just real quick, the Aspen guidelines certainly go over other forms of nutrition as well. Enteral nutrition is just simply a one slide that I summarized everything that Aspen kind of talks about enteral nutrition with, and we're going to harp on that a little bit more here in a second. But when can we use enteral nutrition in a critical care setting? Basically, they really strongly recommend it needs to be started within 24 to 48 hours on the mission in these critical care patients. That 48-hour period is very important. After that, within 48 hours, if we start to feed the gut and keep the gut working, we are going to have the gut will have less permeability, diminished activation and release of inflammatory cytokines such as tumor necrosis factor, and an overall reduced systemic endotoxemia. Of course, the benefits of enteral nutrition are listed here. I talked about it maintains gut integrity, supports, stimulates blood flow, modulates stress and systemic immune response, attenuates disease severity, and certainly it's preferred. Every study out there there's well-documented results of decreased infectious morbidity, hospital length of stay, and return of cognitive function when we're able to feed these patients by the gut. And what does it mean by maintaining gut integrity? I mean, basically, it maintains it both functionally and structurally. Functionally, it causes the tight junction in intraepithelial cells to be maintained, and so you don't get that bacterial translocation that's potential. You stimulate bone marrow blood flow. You induce the release of CCK, gastrin, all the intrahormonal hormonal agents that are released when we eat, that are stimulated when we eat. And then, of course, structurally, we also maintain integrity by maintaining our villus height. Our height stays out, so better absorptive capabilities. And maybe more importantly, I think we're supporting the immunocytes in the gut that secrete IgA, which contributes to our GALT, gut-associated lymphoid tissue, which in turn contributes to our MALT, mucosal-associated lymphoid tissue. And those are in organs such as your liver, kidney, and lung. So essentially, if we're breaking up that pathway early on, that's where we can affect multiple organs, and that's why multi-organ dysfunction is all too common in our critically ill. And I think mainly because when we're not using the gut, we're basically not allowing our body to kind of heal ourselves. We're not giving it a chance. And so that's certainly a negative of when we do not feed the gut. So all that being said, that's kind of what the ASPEN guidelines say. That was our study results, and that's kind of why we're creating this order form. It's going to be released Monday, and it's in front of you there. And certainly questions might arise, and we have to answer them now or at the end of the lecture. But basically, it allows everyone at least to stop and stimulate thought and conversation about, do they meet criteria? Is this best for my patient? Do I have another route to feed them? And such. So that's hopefully what this order form will allow, and it will be necessary to fill out and sign when we're writing our TPN orders beginning Monday. Moving on kind of to the more second part of the lecture here that I feel like is very interesting and important is I think we've outlined a little bit how important enteral nutrition is and how TPN is not just simply a safe alternative to nutrition is, well, what's holding us back from optimizing these patients with enteral nutrition? And there's certainly a lot of thoughts, ideas out there that I think cause us to stop nutrition for a while, stop tube feeds for whatever reason, and not allow us to fully benefit our patients in the critical care setting. So this is a great paper by Dr. Merrick here that I encourage everyone to find and read themselves. We're going to certainly hit up on all the myths that he goes about, but not in detail to everyone just because of the sake of time. But it's, I think, very important to know how we can improve things here in our ICU. So myth number one, that starvation or undernutrition is simply okay. So a lot of times, how are we treating a lot of things? We're treating a lot of things with bowel rest. We hear this all the time. So it was popularized actually back in the 1970s for the treatment of a lot of active GI disorders, Crohn's, colitis, acute chronic pancreatitis, diverticulitis. And it was postulated, and it made a lot of sense, that if we got an inflamed organ or whatever, that if we allow it to rest, we wouldn't stimulate all the luminal antigens and things that cause it to work, and we would allow it to rest, and hopefully it would heal better. But basically, they've proven that this is a seriously flawed concept, that just giving the bowel rest is going to help it heal. In fact, starvation doesn't inhibit bowel function. The bowel is still working even if it's starved. And all starvation does is simply decrease the splenic blood flow, and it results in profound structural and changes that we talked about earlier to the gut. So really not a whole lot of benefit in a lot of these cases of starvation. And they actually go, the author here actually goes to, as far as to say he likes it the asystole of the heart. If we don't really just stop the heart just because it's hurt or damaged per se. So, with the muscle, sure, but this is not the case with the bowel. Furthermore, even more studies have showed that really, particularly tube feeds or enteral nutrition that's high in lipids and protein has a profound anti-inflammatory effect on the bowel and the GI mucosal. So, very important to know that just because we're giving bowel rest does not mean we're helping the bowel out. They also went on and looked, well, what if we just simply underfeed them a little bit? That's what trophic feeding is indicating versus full-blown just feeding them. A lot of times, I've done this myself. I'll label as trickle feed, just enough to kind of stimulate the bowel, maybe not give them adequate nutrition, but at least we're stimulating the bowel. They studied this real well in the Eden trial, which is a really well done trial, that basically at the trophic level, they basically just gave 20 kilocalories per hour versus full-blown feeding of the 20 to 25 kilocalories per kilogram per day. And so they basically showed on every outcome there weren't actually any difference in outcome, long-term or short-term, no benefit one way or the other between these groups. And so I guess you can take that either way, but their summation was, in the absence of any benefit of trophic feeding, why are we holding them back? So we really should be feeding them at the max rate when we can. And their recommendation was in the critical care setting, 20 to 25 kilocalories per kilogram per day, and at least 1 gram per kilogram per day of protein. Now, I know a lot of you guys know that there's a lot of textbooks out there that indicate maybe even higher doses of those in the critical care state, especially burns or trauma, and that's true. This is what this paper outlined here is saying. So it's not unreasonable to give more, I think, in a lot of issues, but this paper is basically saying at minimal, this is what they should be good. And even the Aspen guidelines indicate protein should be like 1.2 to 2 grams per kilogram per day. So certainly some minor controversy there as far as how much we should be giving them. And it's just kind of interesting. I mean, there's multiple studies here that just kind of showed that people who were undernourished just did worse than the people who were full-blown fed in other studies. This Eaton trial has just been the biggest trial, which has proved there really wasn't any benefit to underfeeding them at all. So myth number 2, that parenteral nutrition is safe. So we've been talking about it, but I describe it as kind of a double hit. We've already talked about we're not feeding the bowel. We're having all those issues happen there. But, of course, all the metabolic, immunologic, endocrine, and infective complications that go along with giving someone TPN. And I mentioned on it briefly earlier, but, we're not only bypassing the gut, but we're bypassing the liver as well, which the liver normally relies very heavily on the portal venous system to provide it rich nutrients when we eat. But when we bypass it, profound structural changes occur early. It takes a while to have more laboratory values show up that they're having liver failure. But on biopsy results, the structural changes occur very early when we're not feeding the gut. And so they've shown that, and of course they've shown that enteral nutrition, of course, is protective for any liver dysfunction. We also are going to have impaired chemotaxis, impaired phagocytosis, bacterial fungal killing, and increased free radical formation with simply using TPN in our patients. And we basically are now infusing an agent that's very high in glucose and fat globules into our system now. And our body's just not meant to do that. And like I said, I think the end result is, my summation of sometimes TPN is, we're just not allowing the body to heal themselves. We're not really giving them a fighting chance when we give it too early. And I guess just to drive it home a little bit more, I just reminded myself there's 2 big studies that were done. The landmark study here that was put in the New England Journal of Medicine in 2011, where they randomized some 4,600 ICU patients to either early or delayed parenteral nutrition, early being within 48 hours, delayed being at day 8, that in every statistical outcome that basically those patients did worse who received early enteral nutrition. And they also showed a dose-response relationship, meaning the more parenteral nutrition they got, I screwed something up. Basically, the more that they got, the worse that they did. So that's the scary thing. That basically, the more that they got, the worse that they did. And then Dr. Halen there, just to be even more of a drama queen here, they documented a double risk of death anytime someone was on parenteral nutrition. So, But enough of bad-mouthing parenteral nutrition. Go back to talk about more the importance of what's holding us back from feeding the gut. Myth number 3, that enteral nutrition is actually contraindicated with vasopressors. And certainly this is makes a lot of sense why we would want to hold it back. It makes sense, right? Vasoconstrictors, they're going to shunt blood away from the splenic system. If people are hypotensive, so maybe decreased blood flow there too. And so it's been postulated that, well, we have decreased oxygen delivery to an organ. Why are we going to increase oxygen demand? It's kind of sounding like the heart again. But, however, when we're saying basically feeding the gut stimulates increase in blood flow. And every clinical trial that's tried to prove that there is true ischemia present has just been false. Every experimental clinical study has proven that it actually increases gut blood flow. And so ischemia, now there are some trauma literature that's out there that did show some ischemia 1% of the time. But if you actually look at those studies in detail, it's really kind of tough to know what actually caused the ischemia. They just know they were getting tube feeds at the time that they developed bowel ischemia, and that was only 1% of the time in a large study. So really nothing's really been proven that we're actually going to make these patients have bowel ischemia while they're on pressors by feeding them. In fact, it should be protective. Some of the studies I did do it on, of course, is post-cardiac patients who were on, all of them being on pressors. During enteral feeding, they measured their cardiac index, their endothelin, green clearance, and their glucose absorption, all increased while their gastric tonometry actually remained unchanged. And then in a multi-study center here, that all of them had demonstrated lower hospital mortality if they were fed within 48 hours. All these patients were on usually multiple pressors, both Levophed and vasopressin, and the greatest benefit we've seen are those who are actually the perceived to be the sickest as well. So, myth number 4, that our enteral nutrition can be contraindicated with high gastric residual volume. So, it's certainly common practice when someone's on tube feed, as an NG tube in. We're kind of expecting this to be an accurate measurement that the nurse is giving us to how much is still in the stomach after we're going tube feeds, and we're trying to use it as a marker usually for risk of aspiration, right? Lots in the stomach shouldn't be at increased risk for aspiration. Basically, they've come to the conclusion that there's no study to actually support that there's an actual relationship between increased gastric residual volumes and aspiration. Basically, meaning if you have high gastric residual volumes, which they're calling at 400, versus low gastric residual volumes, which is like less than 150, people with 400 did not have increased risk of pneumonia, did not have more incidence of pneumonia. So it doesn't mean you're going to get it, and if you're low, it doesn't mean you're not going to get it. It's all individualized to the patient is ultimately what it means. And it should be known that in this study, they threw out people who had surgery in the last month, or upper GI surgery in the last month, history of GI bleed. So they threw out a lot of high-risk patients, but their point was made that it's just a poor relationship between gastric residual volumes and risk of aspiration. I know there's certainly some places that really try to, and I think we should do the same thing here at our facility, try to come up with more standardized number of what's considered high. Someone high might be 200, another might be 400, but having more of a standardized something in place as to when should we maybe cut off the use of enteral nutrition. Myth number 5 is that it's contraindicated in patients without bowel sounds and or postoperative ileus. So this was actually described in 1905 by Dr. Cannon, who simply suggested in a paper that if there's no bowel sounds, there's no bowel function, and somehow this is taken off as being a major part of our clinical exam as far as when or not can we feed these patients, or when have they fully recovered. And basically, every study since in the last 20 years has not proven any relationship between bowel sounds and bowel function that's out there. And certainly, return of bowel sounds after abdominal surgery has been commonly regarded as an indicator of when the resolution of post-op ileus has occurred and when it's safe to start feeding them. However, really the absence of bowel sounds does not mean that the bowel's not working. Bowel sounds simply result from moving air through. So a lot of times it's from us swallowing air, from us eating and things like that. A lot of times they even proved that after a major laparotomy, there wouldn't be bowel sounds. They would actually inject air directly into the duodenum, and immediately they'd have bowel sounds in all 4 quadrants. A lot of times the absence of bowel sounds after surgery, I've seen it described a couple different ways, was basically they just thought usually we've kind of emptied out the bowel of some kind, and there's no air moving through. And of course, our critically ill patients, either they're on a ventilator or just laying there, they're not swallowing a lot of air, so bowel sounds aren't present. But the gut is still functional unit is basically the issue here. And one study done by Dr. Waldenhausen, actually they measured the GI myoelectrical activity of the bowels, the MMCs and all that, and correlated it with bowel sounds at basically immediately post-op after a laparotomy, after the bowel's been manipulated, handled, and everything, or even anastomosis performed. They measured the GI myoelectrical activity. All of the small bowel had electrical activity, sufficient enough for peristalsis. But bowel sounds wouldn't be heard until day 2.4 was basically what their study came out to be. So, and then they wouldn't have passes of flatus till day 5. But all of them had actually a functional gut. So basically the summation was there's just poor correlation with auscultating bowel sounds and when is it okay to start enteral nutrition. Another myth that enteral nutrition is contraindicated following a GI surgery. Kind of talked about this a little bit. Our classic surgical training is that, due to reflex inhibition, the bowel is going to kind of become inactive following surgery. It goes through a normal post-op ileus of about 3 to 5 days. And also, if we've done any type of anastomosis, there's always great concern that if we put any more tension or distension on it, that we could break down our anastomosis. And so this is also a reason why we're frequently not feeding these patients for walks. We're waiting for all these things to come back. But motilities have demonstrated that there is return to small bowel peristalsis within hours after a laparotomy, And they actually did some radio-labeled albumin studies, which pretty much 94% of them got absorbed at 5 hours post-op. So the absorptive capability is certainly still there. And the biggest study, I listed this canine study, it's not a human study, there's human studies out there, but this was the biggest study that's actually been probably used the most to support this, is that on all these canines that they had surgery, that when they fed them early, all their post-operative ileus recovered much quicker compared to the standard therapy of not feeding them and waiting for return of flatus or a bowel movement or whatever. So really they strongly feel that feeding patients can simply help reduce or actually hasten a post-op ileus, rather than our thought process, if it's not working, it's going to sit there and they're going to get worse. Really, it's been proven to actually hasten an ileus. Also, as far as overall wound healing, we know if we're getting adequate nutrition, they've shown that there's actually increased burst strength at the anastomotic sites due to increased collagen concentrations here. So, and our body's normally making several liters of fluid on its own that's going through, and so if we're giving them an additional 750 ml or less than a liter of enteral nutrition, they kind of scoff at the idea that one additional liter could actually cause enough distension or issues on our anastomotic site to cause significant problems, since we already should be producing several liters on our own anyways. And then, of course, overall, multiple studies on increased wound healing, greater wound strength, higher wound hydroxyproline collagen accumulation, less wound infection, shorter hospital stay with earlier nutrition. So I'm getting tired, so I had to summarize all these here. For the sake of time, that was going to be my excuse. For the sake of time, I was going to summarize these. The other myths that are covered here that I thought the paper did a really good job on as far as covering. That's why I encourage you guys to kind of take this paper and hopefully read a little bit more on your own. But just to go over them here, that earlier, I think the myth number 7, I think we do a really good job here at this facility that we know isn't true, that early enteral nutrition is not important in patients receiving mechanical ventilation. Basically, one large study showed there was actually a 50% reduction in mortality on patients who were mechanically ventilated and showed enteral nutrition. Their length of stay on the ventilator is shorter and everything, and I think we're seeing that more here. When patients are mechanically ventilated, we can put an oral gastric tube in and just start feeding them. So that's been good. Myth number 8 goes along with kind of high gastric residual volume, that post-pyloric feeding is going to reduce your risk of aspiration. Again, there's no studies actually proven this. It's really just individualized patient. It's really, one meta-analysis basically said the risk of pneumonia was just unrelated to the route. If their patient is a high risk to begin with, they're going to be a high risk. If they're a low risk, they're going to be a low risk despite where we put it. Myth number 9 is enteral nutrition is contraindicated in patients with an open abdomen. Basically, multiple studies kind of proved it. Number 1, it should be feasible to feed these people, and of course, they all have improved outcomes. Myth number 10, I think, is one of the more interesting ones as well. That enteral nutrition is contraindicated in patients with pancreatitis. Of course, that's classically taught. We don't want to feed these patients. But randomized trials did prove that improved infectious outcomes, shorter length of stay, etc. But they did break it down, of course. If it was considered mild acute pancreatitis, they did recommend an oral low-fat diet. If it was moderate to severe, they did recommend a jejunal feeding route as far as feeding these patients. But all of them improved with enteral nutrition, early enteral nutrition. And then myth number 10, that patients must be myth 11, patients must be fed in the semi-recumbent position at 45 degrees. This is a great idea. I mean, we should do this for all our patients anyways, but essentially, just because if they're having to lay flat for some reason, we shouldn't stop us from feeding them was the basically overall thought process there, that again, they didn't have an increased risk of aspiration when they were laying flat versus laying up. So we should still continue to feed these patients. Well, that's the conclusion of the lecture. I hope more than anything, like I said, just the whole goal here is to try to strive to make our hospital better. I think that paper kind of proved that we had room to improve. I think we already have improved over the last year, just my personal observation of using enteral feeding. But I think we can be more aggressive with using the gut when it's available is the bottom line. And this way we're not holding back our patients to heal up on their own. But this time I'd be happy to take any questions concerning any issues with those myths or also with the order form. Most of the questions with the order form and the new TPN, I'm going to turn over to John or Carolyn that can help us out with that. So, but any questions? I knew I did that good of a job. So thank you very much. I appreciate it. What's that? Yeah, exactly. I guess I want mine. I already got the PowerPoint made up.